Again, just since people are still trickling in, I'm going to introduce myself. I'm Diljit Singh. I am a gynecologic oncologist currently practicing and based out of DC. I'm the current president of PNHP, and I was lucky enough to be the PI on this moral injury project. I'm going to get going because we have a full schedule tonight. I want to thank everybody who is on the call, who participated in the research, the surveys, the interviews. Without you, this data would not have been possible to obtain. We appreciate your time, your commitment to the profession and to the project. Also, I want to thank everyone who's on the call who worked to recruit for the project. We appreciated your pressuring your colleagues and friends. At PNHP, we became engaged in this work as we noticed the increasing financialization of our system with loss of physician autonomy and worsening moral distress among our members. Physicians stayed focused on how to provide best care while the system around us morphed into a system run by non-physician employers and the health insurance industry, with the focus on making the most money possible. Unfortunately, organizations like the AMA kind of lost the forest for the trees, right? They always talked about maintaining physician autonomy and patient choice, but clearly they failed at both of those goals and really completely misdiagnosed the problem, failing to see the underlying disease, focusing on this concept of burnout that we'll talk about, but talking about burnout and individual physician solutions. Yeah, somehow I can't get over the idea that, like, if you create a chief wellness officer, that's going to solve our crisis. So superficially, like, the project focused on how financialization aggravates systemic racism and causes moral injury for physicians who are not able to provide the care they know is needed. One of our goals with the project was to shift the conversation away from this flawed concept of individual burnout. Not that it doesn't exist, it absolutely exists, but for most of what we're talking about, that isn't the root cause. And aim to make the conversation about fixing the broken system that's clearly been taken over by people not interested in saving and improving lives. And I'll say for me, like, narrative research is not the kind of research I previously did. And ultimately, I've been really excited about you'll hear about the pieces, but regardless, like, an opportunity to hear physicians' voices is really important. We are not people who are used to putting our voices forward. We're used to putting our patients' voices forward. And this project has been work in progress for me, from seeing that and really appreciating that. We're not done with the project even now as it stands. We're finishing things up, but even beyond when we finish the project, as you'll hear about it tonight, we're planning to continue this work, and hope you all stay tuned for that, perhaps get involved in the projects and next steps. Just as a reminder, I appreciate you all on the call who participated in the study, but know that survey and interview responses were anonymized through ID codes. PNHP will never share any contact information or study respondents' info. Tonight, we will be sharing this informal, like, very preliminary first release of our survey findings, with lots of additional academic evaluation and releases to come. We're also going to share the work PNHP is doing to address the issues of moral distress and reclaiming physician autonomy. We'll offer some opportunities to get involved and really work from the concept that we are the solution. We hope you'll consider becoming a PNHP member or making a donation. We're really the only organization focused on reclaiming physician autonomy so we can get the right people making the right decisions for our patients and our profession. I'm going to first introduce Dr. Corinne Frugoni, PNHP member from California, who's done a lot to further this work, to tell us more about the project.
Thank you, Diljit. I'm a family physician living in Humboldt County behind the Redwood Curtain, California. I work part-time at an exceptional not-for-profit hospice organization. I joined PNHP in 1989 when I was a medical student, where I stopped by a small rickety table advertising PNHP at an American Medical Student Association conference. Shortly after I signed up, I was diagnosed with a cancer, which was scary enough, but I was so clueless about health insurance. I had the bare minimum coverage to cover 2 surgeries. My surgeon was able to negotiate price reductions, which I paid over a number of years. Since then, my commitment to Medicare for All has only strengthened and deepened as many of us attempt to provide the best care under an increasingly dysfunctional healthcare system. What Diljit just described is the research project that PNHP started over 1.5 years ago. It began with 3 physician focus groups to identify themes and design research tools. Absolute confidentiality, to repeat, absolute confidentiality for all participants in the study was guaranteed. This was followed by a national physician survey to collect wide-ranging data. Anand will go into more detail following me. Then 30 in-depth interviews were conducted with physicians to gain greater insights into moral injuries and inequities. Not to forget the other side of the equation, we are in the process of conducting patient focus groups to better understand their lived experiences. While we wait for Anand to give his talk, we would like to engage you, the audience, by answering our first question, which will be coming up on your screen. The question reads, in the past month, how often have you experienced distress from knowing what a patient needed, but were unable to provide it due to constraints outside your control? Thank you.
Thank you, Corinne, and thanks for all the work you've done supporting the project. Now we'll hear from Dr. Anand Habib, one of the leading physicians on this project, participating in the work and the interviews, to share our initial survey findings. Anand is working tonight, as many of us often do, and so we have a recording of Anand and those findings.
Good evening. My name is Dr. Anand Habib. I'm a hospitalist physician and health policy researcher at UCSF, and I'm also a member of the Physicians for a National Health Program, and I'm excited tonight to present some of our initial findings from our moral injury survey. So first, in terms of our survey aims, they were threefold. First, to identify key systemic contributors to moral distress among a national cohort of physicians. Second, to evaluate the association between severity of moral distress and physicians' prior or current consideration to leave their jobs. And third, to assess the association between physicians' demographic, professional, and practice characteristics and the severity of their moral distress. So accordingly, our survey design asked demographic characteristic questions, including gender identity and racial ethnic background. Second, professional characteristics, clarifying if someone was a board eligible or certified physician, a physician trainee, or another type of health professional, their clinical specialty, and their level of clinical experience. Third, asking if they practice in public versus private institutions, in a clinic versus hospital setting, and asking them to estimate the proportion of patients for whom they care who are uninsured or who come from racially or ethnically minoritized backgrounds. In terms of our outcomes of interest, first, we measured the severity of moral distress using an adapted measures of moral distress in healthcare professional survey, which asked 22 questions, each of which could be scored in terms of the frequency and the severity of distress encountered for each of those situations. We asked if the respondent had ever considered leaving or left a position due to moral distress, whether they were currently considering leaving a position due to moral distress, and asked them to self-rate their level of burnout. So how did we measure moral distress? So we started with the original MMDHP. This is the Measures of Moral Distress Among Healthcare Professionals survey. That instrument had 27 questions assessing potential root causes of moral distress at the patient clinician, team, and interorganizational level. We then conducted physician focus groups to try to illuminate some systemic causes, healthcare system-wide causes of moral distress. And we heard things like physicians are the face of this broken healthcare system and have to own it even when it's not our faults. We then took 8 original questions from the MMDHP, added 14 new questions, including questions like feeling uncomfortable as the face of the organization or system I work with, working within a system that prioritizes financial goals over best patient care. So in terms of our survey respondents themselves, we were humbled and excited to have received over nearly 1,800 responses. And this was not just among physicians, but also among medical students, nurses, APPs, healthcare advocates, patients, and other healthcare professionals. Of those, about 1,400 were physicians, of which 250 were already retired. And that left us with 1,126 currently practicing physicians, of which about 10% were physician residents and fellows. Among those 1,126, 60% were women, 66% self-identified as white or Caucasian, and 11% identified as coming from a group that is considered underrepresented in medicine. In terms of their professional characteristics, respondents practice across the gamut of clinical specialties, but the most common, 36%, practice general adult outpatient medicine, and furthermore, 44% practice primary care. This includes things like general pediatrics, as well as family medicine. Our cohort of practicing physicians is quite experienced. 37% have practiced over 20 years. In terms of the settings in which they practice, oftentimes 38% of the time they practice across inpatient, outpatient settings and public versus private hospitals. And when asked to assess the proportion of patients for whom they care who are either uninsured or who come from minoritized backgrounds, 36% estimated that 6 to 25% of their patients are uninsured currently, and 32% estimate that 26 to 50% of their patients come from racially or ethnically minoritized backgrounds. In terms of some of our outcomes, 38% of our practicing physicians who we surveyed reported moderate burnout. Only 1 in 8 reported no burnout at all. 69% of practicing physicians have previously considered leaving or left a job due to moral distress. And we were quite surprised that 46% of physician residents and fellows have already considered leaving a job due to moral distress. 1 in 4 individuals is currently considering leaving a job due to moral distress. In terms of that severity of that moral distress, so quite a broad range, but what we found is that the level of distress often exceeds the frequency with which morally distressing situations are experienced. For 18 of the 22 questions assessing potentially morally distressing situations, the level of distress was very distressing, a 4 out of 4. In terms of the overall moral distress scores, so for each of the 22 questions, we multiplied the score in terms of frequency and level of distress. So for a potential 16 points for each of the 22 questions, a maximum total score of 352. The median score was 137. The mean was 144. And for some context, physicians in the original validation study for the MMDHP had a score of a mean of 96. So what is causing the greatest moral distress among practicing physicians? First, having excessive documentation requirements that compromise patient care and interfere with work-life balance. Second, feeling betrayed by a healthcare system that hinders one's ability to provide good patient care and feeling unable to provide patients with the best possible care. Third, having excessive administrative burdens because of insurance prior authorization and denials of care. Fourth, making diagnostic or treatment recommendations to patients that one knows that patients will not be able to pursue because of the limitations of our healthcare system. And fifth, feeling the financial goals of one's organization conflict with one's own goals of best patient care. So to briefly summarize, we received nearly 1,800 survey responses, including 1,126 responses from practicing physicians. Most physicians reported moderate burnout. Mean moral distress was greater in this cohort of physicians than what has been previously reported in the literature. And we found that the level of distress often exceeded the frequency with which potentially morally distressing situations were encountered. Excessive documentation requirements, administrative burdens, and conflicting financial goals contribute to physicians' moral distress. Nearly 70% of physicians have considered leaving or left their jobs due to moral distress, including 46% of physician trainees. And 1 in 4 physicians currently are considering leaving a job due to moral distress. This is just the beginning. We're going to dig into these findings and results further, and we're very excited to be able to provide more results in the coming months. But the big takeaway is you are not alone. Many of our colleagues are experiencing a lot of moral distress, and we at PNHP are determined to seek out solutions and hopefully address these issues. Thank you very much.
Hard to believe, right, that 70% of physicians have considered leaving a role due to moral distress. But to Anand's point, again, it means we're not alone. We're all here tonight. This is the first step. With this many minds and hearts in the process, we can only succeed. Now we'll hear from Dr. Marie Hobart and her personal professional experience with our healthcare system, and to share some quotes from the free write part of the survey. Welcome, Marie.
Hello, everyone. My name is Marie Hobart. I'm a psychiatrist, and I've practiced in community psychiatry for my entire career. I also joined PNHP in 1989. Psychiatric care has always been somewhat discriminated against in our insurance system, and joining the organization was one of my ways of fighting against that discrimination. I have semi-retired, in part because of the moral injury issues that have been outlined in our study. I currently work as a consultant in a primary care. Tonight, I'm going to share my own story of a patient, their experience with our healthcare system, and how it impacted me. I was asked to see a patient on an urgent basis. He is a Latinx man, married, father of 2, employed full-time. He has suffered greatly from early childhood trauma, systemic racism, and the trauma of our carceral system. He has struggled with PTSD, addiction, and depression. He was in the ER just a few days before this visit with intensive suicidal thoughts that were very distressing to him and to his family. It was very difficult for him to admit that he needed help and to even ask for help. So just the fact that he came in was huge. He was very much wanting to do the right thing for himself and his family. As a full-time worker, he actually has health insurance through his employer. However, our institution had been unable to negotiate a favorable contract with his insurance plan. We had been receiving notices that anyone covered by his health plan would no longer be accepted by our clinic or our entire institution. This was not just for mental health care, but for all of his health care and presumably his family as well. He was starting medication, starting counseling, in need of frequent follow-up, and suffering from a life-threatening condition. And by the next day, after I'd seen him, his insurance would no longer be accepted for care at our institution. We had no clear source of referral except perhaps the federally qualified health center in our region that has a long behavioral health waiting list. It was unclear if there would be any way to make an exception, given the seriousness and the severity of his condition. On a personal level, I was devastated and angry, recognizing that we do not have to practice in this type of environment, where patients can become excluded from care for strictly financial reasons, even when they have insurance. So this is one of many experiences that I've had, and I'm sure you all have as well. Recognizing that we do not have to practice in this type of environment where patients can become completely excluded from care. So I'm going to share some of the quotes from the study. And while I am doing that, I would encourage you all to just put a word or two in the chat about how it felt to you when you had the experience of needing to provide care, wanting to provide care that you were not able to provide for a patient. So I'll start with the first quote. I feel distressed by the inability of patients to be evaluated and treated by a physician because this does not align with the financial goals of the institution. Another, I teach medical students and find it difficult at times to keep it positive. I want to get them ready to be doctors, but don't want them to feel defeated before they even get started. My current job is not too bad, but the pressure to see patients faster and faster, leaving documentation to the end of the day, has been a huge issue. I don't feel a high degree of moral injury due to not providing good care to patients, but I feel a great deal of injury to myself over my career, not being able to earn a living without excessive documentation in order to provide the care that's needed for my patients. I also experience a great deal of distress about insurance covering medications for some patients and not for others. The inequity is disheartening. I feel like the system is complicit with the larger state to continue to marginalize my patients. And a final quote, we are always understaffed or short in some way. Everybody is exhausted. I have so many conversations with other mid-career docs that want to slow down or start a side gig or move to non-clinical or even retire early. Who will be left? These stories and experiences are hard, but here we are together, advocating to make a difference and supporting one another. As I've shared my story, please keep sharing your stories with one another as we fight for a healthcare system that cares for all patients and for ourselves.
Thanks so much, Marie, for sharing. And thank you for everyone who commented in the chat. None of these things are easy to talk about. Our system has made the medical part like the easy part. During our interviews, same, we heard so many challenging stories like yours, and how, in spite of this messed up system, physicians still manage to find fulfillment in their individual interactions with patients. Thanks, Marie, for the work you've done and continue to do to organize physicians. And thanks for sharing your stories and those other comments. Now, Rebecca DeLay, our awesome organizer, study coordinator, data analyst, like you name it, she does it. We'll share some updates about more info to come.
Thank you, Diljit. And thank you again, Marie, for sharing that part of your story. As Diljit said, my name is Rebecca DeLay. I'm a national organizer for PNHP and the lead study coordinator for this project. And I just want to share some quick updates on the release of more data to come. So we'll be sharing the next phase of the survey analysis and the preliminary interview data at PNHP's annual meeting the first weekend of November in DC. Our team of IRB-approved physicians, students, study consultants are all working to analyze the results of the survey and to be able to provide a more in-depth understanding in the consequences of those findings. For the interviews, we're currently in the coding process of that qualitative aspect of the project. As we've heard earlier tonight, we interviewed 30 practicing physicians with a range of experiences of both moral injury, their medical practices, and really from a diverse group of backgrounds. If you have not yet registered for the annual meeting, you can do so. We've added a link in the chat. Please join us. It's going to be a great weekend. I hope you can. Second, we will be publishing a PNHP report similar to our past Medicare Advantage overpayments report and harms report we've put out in previous years. This report will be on all of the data we've collected and will be released at the end of the year or early of next. Finally, we'll be releasing an academic publication that'll be on the IRB approved data we collected to be published in an academic journal. This will be a scientific report including both those quantitative and qualitative metrics. Now, here at PNHP, we're doing our part to share and release data on this project, and we really encourage you all to do so as well. Please talk to your colleagues, your medical societies, and the organizations you're involved in with your experiences about moral injury and also of our findings. We'll have more information on how to disseminate those findings as we continue to release them. And thank you again all for participating. We're truly grateful.
Thanks, Rebecca, for that info and for everything you do. Like you said, there'll be more info and data come. Now we're going to spend a little bit of time learning about PNHP, who we are at an organization, what we will achieve. For this, Carol Paris, one of the PIs on the project and the vice president of PNHP, will join us.
Thank you, Diljit. Good evening, everyone. As Diljit said, I am the current vice president of PNHP and a retired psychiatrist. I have been asked to introduce you to our organization, Physicians for a National Health Program. To those of you on the call who are already members of PNHP, I'd like you to use this time to imagine what you would say if you were in my shoes right now. And for those of you who are not yet members of PNHP, it is a 501c3 nonprofit organization of physicians and healthcare professionals who advocate for a national health program. PNHP began in the 1980s and has grown to over 20,000 members. I joined PNHP in 2009. At that time, I was the owner of a small outpatient private practice, and I was the only game in town. I was the only practicing outpatient adult psychiatrist in a community of 110,000 people. So I felt an obligation to accept insurance because most of my patients couldn't afford to see me if I didn't accept insurance. But let me tell you, by 2009, I had become so fed up with the hassles of commercial insurance that I said to a friend one evening, "There has to be a better way." And she said, "Have you heard of Physicians for a National Health Program?" Well, over the years since then, PNHP has given me the opportunity to be an outspoken critic of our profit-driven healthcare system, arming me with sound policy and research to fight against the profiteering and mind-numbing complexity that puts profits before patients. Our campaigns are laser focused, not only on ending profiteering and complexity, but also on improving traditional Medicare and ultimately achieving a national health program. And what I've come to realize is that my membership and active participation in PNHP, rather than being a drain, has actually served as an antidote to my own moral distress. And every one of our campaigns helps to restore physician autonomy and kick the profiteers out of our exam rooms. PNHP is the only physician group fighting to restore autonomy in our practice of medicine. So I invite you to join PNHP in this effort by becoming a member today or by making a donation to support our work. And now I think you will see our second question pop up on your screen. How familiar are you with Medicare for All as a solution to the systemic problems we face in our current system?
Thanks, Carol. And I look forward to hearing everyone's answers to that. We are so lucky, Carol, to have you as a leader, and it's been such a pleasure to be your colleague and to get to be your friend. As Carol mentioned, those links are in the chat. Um, I honestly, it was a good reminder for me to think through all we do and the idea that, yes, it's a lot to do, but it's also part of being part of the solution. Next up, we have one of our amazing med student leaders, Kathy Craig, who's also a vital leader of our reproductive justice interest group. And she's going to give you more details about specific programs that we're doing. Kathy?
Thank you, Diljit. Hi, everyone. My name is Cassie Craig. I'm a third-year medical student at ChiCom in Pikeville, Kentucky, and I'm also on the Inclusivity and Outreach Committee of Students for a National Health Program, which is the student branch of PNHP. I'm going to share with you guys a few ways in which PNHP has been doing exactly what Carol just mentioned, fighting back. We currently have a team working on an equity report that will be coming out in the next few weeks. This project looks at the impact of Medicare Advantage on racial health inequities using data-driven critical analysis. The report will assess Medicare Advantage insurers' claims that their programs promote equity. Similar to the Moral Injury Project, it looks to support the advocacy efforts of the organization by providing insight to the drivers of inequity in the system and to propose a solution and policy recommendation. We hypothesize that these financial motivations drive inequities and moral distress. We will be sharing this report with legislators and policymakers once it's published, and this is one of the many reports that PNHP has released to fight against profiteers. PNHP members are also organizing within medical societies. As we've heard, many of these associations put the focus on individual burnout and not the systemic causes of moral injury. These are the places that we need to be discussing moral injury because these societies affect our practice of medicine. There are currently groups that we have organizing within the American Academy of Pediatricians, the American Psychiatric Association, the American College of OB-GYNs, and our newest group that was formed in the Infectious Disease Society of America. I personally am a member of both the reproductive and psychiatry meeting interest groups, where I've been able to further advocate for reproductive and mental health care within our push for the larger cause, which is single payer. Working in these groups has given me so much hope for my future career, hopefully in psychiatry. If you would like to join an existing member interest group or start a new one, there will be a link in the chat for you guys to see. The final organizing effort I want to discuss is our legislative work. In 2024, PNHP led 24 legislative meetings with national congressional offices, and then earlier this year, we led 44. It's truly incredible, and because of this work, in 2024, the Biden administration did not increase the insurance funds given to Medicare Advantage insurers. And the very next day, we saw United Health stocks crash. These companies are taking money that should be going to patient care. It was the efforts of PNHP that stopped them from pocketing $20 billion that should be used for healthcare. Lastly, on November 3rd, we will be having an advocacy day in DC for in-person legislative meetings as a part of our annual conference. If you're interested, please register using the link in the chat. We would love for you to join us. Thank you for your time.
Thanks, Cassie. It's great to hear, right? We are making an impact. We're doing what we can, and we're educating. And I'm reading these questions in the chat, and they're great questions. Come to our meeting. That's what our meeting's all about. Learning how to talk to people because there is so much misinformation out there. All right, next we're going to hear from Dr. Ashley Dulon. She is a gynecologic oncology fellow and a awesome member of our board of directors. Ashley?
Thank you, Diljit. So hi, everyone. My name is Ashley Dulon. Like Diljit said, I am an OBGYN currently completing my gynecologic oncology fellowship training in Western New York. I have been a member of PNHP since I was a medical student, and I am now a member of the national board. As Cassie shared, we at PNHP are fighting back against profiteering in healthcare. As we think about our shared goal of Medicare for all, the idea of achieving a system of equitable, universal healthcare in our country can feel abstract when there are so many barriers in place to making progressive change in our current political climate. Moral injury is an epidemic amongst healthcare providers within our country because of these very barriers and the control private insurers have over our hospitals and medical societies. As a reminder, moral injury in healthcare is a psychological distress experienced when physicians know the care their patients need or are unable to provide it due to limitations beyond their control. These limitations are the direct result of the profit-driven practices championed by private insurers and non-physician employers in this country. These barriers not only harm physicians, but compromise our ability to provide the best possible treatment and outcomes for our patients. As we've learned tonight from our initial review of the data from the Moral Injury Survey, this is a nearly universal experience. This is why we need systematic reform and why we at PNHP believe that the shared experience of moral injury can be harnessed to build power in our movement. If you took the Moral Injury Survey, you may have noticed that we asked about your experience with burnout. This word is a hot topic in the world of wellness and medicine, particularly with the bureaucratic leadership of our hospital systems and medical societies. Have you ever noticed that the proposed solutions to burnout are all focused on what you can do as an individual? What if we were able to create a solution that would fix the root cause of the issue rather than trying to place a band-aid over the side effects of our system with tactics like deep breathing and yoga? And turning the responsibility for the physiologic and distressing response we mount in our day-to-day practice back onto us as individuals, the profiteers retain their power and divert our focus away from the larger systemic issue at hand. Some of the largest organizations representing physicians have not backed us in our goal of achieving equitable healthcare for our patients. This is simply because organizations like the AMA do not want to take on insurance companies. Isn't doing right by others and helping our patients why most of us decided to join this profession in the first place? Shouldn't the organization that we choose to align ourselves with support us as physicians instead of backing the very entities that we make us think that we are in fact the problem and not the system in which we found ourselves? I know this tactic has worked on me when I felt guilty for not prioritizing my own well-being amongst my 80-hour work weeks and thus not being fully present with my patients. In reality, it's the system I work within that has led to this being the case and not my own fault. Physicians for a National Health Program is the organization that has had my back as a physician practicing within our flawed system and will have yours as well. We believe that organizing around our shared experiences and moral injury will help us build power with our colleagues toward achieving our goal of Medicare for all. If anything we have said tonight has resonated with you, I ask that you join us in our efforts toward a system that will grant you the ability to practice the way that you imagined when you first decided to become a physician or a healthcare provider. A national health program would remove the conflict of interest between our patients and profit-driven metrics. I am so encouraged by all of you who have shared your stories with your responses on the Moral Injury Survey. I'm filled with hope and confidence that together we can build a system that prioritizes health over wealth and allows us to take back our autonomy as healthcare providers with Medicare for all.
Thanks so much, Ashley. I remember how rough it was being a Gyne-Onc fellow. So appreciate the time you give this organization and the work you do. As we've heard several times tonight, this is not an individual problem. The system is broken. People are commenting in the chat accordingly. And really the wrong people with the wrong goals are making all the wrong decisions. To talk a little bit about, how we address this as an organization, Dr. Toby Trilliger is internist in Atlanta, one of our fabulous board members, someone I was lucky enough to get to know a little better while I was working in Atlanta. Welcome, Toby.
Thanks so much, Diljit. And hey, everyone. Thank you again for joining us tonight. As Diljit said, my name is Toby Terwilliger. I'm an academic hospitalist in Atlanta, Georgia. I sit on the board of directors at PNHP, and I co-chair the Georgia chapter with Belinda McIntosh. Tonight, I'm going to be discussing why we as healthcare providers should take a personal interest in moral injury. So we've heard a lot tonight about when we talk about moral injury in medicine, this really isn't an abstract concept. It's something that's deeply personal and something that I suspect each of us has felt at some point, either at the bedside, in our office as we fill out prior authorizations for standard of care management, or even at home when we replay the day in our heads. And like many of you on this call, I entered medicine because I believe in healing, advocacy, and service. But too often, this system asks me to compromise those values. Maybe it's that prior authorization that delays care, or an insurance denial that forces me to settle for a substandard medication. Each of these moments chips away at my sense of purpose. And when I experience these exposures to moral distress again and again, it wears me down. I'm sure we can all think of a friend or a colleague who left medicine or transitioned to direct primary care because of the injuries inflicted by the insurance industry. It's crazy that 69% of physicians have thought about or have left medicine. And if we don't get to the root of the problem, we are going to continue to lose good doctors to early retirement or career changes. But again, it's not just about us. It's also about what our patients experience every day. And for me, as a practicing physician, there's no feeling worse than having to face a patient after an insurance middleman denies them the care that I know they need. It makes me feel utterly powerless when a peer that has never seen the patient before denies my appeals for coverage. And then when I have to return to the bedside to tell the patient that they're not getting the care that we had hoped for, it's completely devastating for us both. No patient should be neglected because a for-profit system sucks the life out of us providers. But unfortunately, that is exactly how our system is designed, and our patients are suffering most of all. So, again, I ask you, why should all physicians care about moral injury? And for me, it's really about self-preservation. I don't know how many times I can get beaten down by this for-profit system before I become jaded and before I lose the love for what I do. Labeling what I experience as moral injury allows me to channel my advocacy, and advocacy is what allows me to keep going in this profession that I love so much. I truly believe this is not a niche issue. It is central to our identity as physicians, to the future of our profession, and to the health of our patients. If we want a sustainable, humane, and effective healthcare system, then addressing moral injury has to be at the top of our agenda. So if any of this tonight has resonated with you, you may wonder what you can do to get involved. If, like me, you find yourself wanting to reframe this conversation about burnout, if you want to reshape the future of our healthcare system so it works for physicians and for patients, it's time to share your stories and to share the amazing work that Carol, Rebecca, Diljit, and the entire moral injury team have done. So how to share this work? The good news is we've made it easy for you. We have dropped a one-pager in the chat, which you can use along with your personal story to encourage colleagues to get involved. If your institution has a wellness committee, encourage them to use the one-pager to stimulate a discussion of moral injury and maybe even turn it into a journal club. You can also bring it up at the next staff meeting and ask your leaders what they are doing to combat moral injury in the workplace. You can also use this to start a conversation about moral injury within your medical societies. I'm a part of a group of PNHP members who are hosting a workshop at the Society of General Internal Medicine this coming year, and we're going to be encouraging attendees to identify, analyze, and confront examples of moral injury in their practice. This is a really great way to get involved, but some other ideas include writing an op-ed or publishing in your society's newsletter or message boards to raise awareness. And finally, talk about this with your peers and your colleagues. Chances are they've experienced moral injury, but just haven't put a name to it. Share your story and engage them in a conversation about how we as a profession can begin to grapple with these systemic issues. And of course, as we've heard tonight, if you're not already a member, join us here at PNHP. Thank you all so much, and thanks again for being here.
Thank you. Thank you, Toby. I still have wonderful memories of your beautiful back porch and a lovely dinner. We're so grateful to hear the work you're doing and everybody who's sharing their thoughts, their feelings, their emotions in the chat. Some of the preliminary info that we actually haven't yet presented suggests exactly what Toby was talking about modeling, this concept that getting involved and taking action can ease some of the symptoms of moral distress and injury, right? The idea that advocacy can heal us, heal our profession, and help heal our patients. Please click on the link in the chat and fill out our engagement form. Let us know how you'd like to stay involved with the project and with PNHP. We're all here tonight because we've experienced moral distress, because we're committed to the work we do, taking care of patients, helping our patients get the longest, best quality lives they can. So much of what we believe in, science, public health, having compassion and empathy for those around us, is under threat. We are a community of activists, researchers, clinicians, healthcare advocates, all working to save our profession, to save our patients, and to save our healthcare system. We hope you'll support the work we do. We hope to see you in DC. It's going to be a wonderful weekend and a wonderful meeting and a wonderful lobby day on Monday. We hope you'll join us. So much of the frustration and the other discussions that we're hearing in the chat, we'll be entertaining a lot of those questions and hopefully have time over a glass of wine, over dinner, to continue these conversations. I have struggled a lot with continuing to practice as a gynecologic oncologist, and I say this every day. It's my work in PNHP that allows me to go to work and to not feel guilty that I'm part of the system, but to know that I'm doing both sides. I'm doing my best to take care of patients in the system we have, and I'm doing my best to see what we can do to make the system better. I know I'm seeing people say, like, I don't have time. And one of the wonderful things about PNHP is that we don't want this to be one more hard thing to do on your list, right? Ideally, we can find ways for you to be engaged that you can work into your busy schedules, but that'll hopefully help, like, you're being part of the solution. And at some point, yeah, you'll have to make it to one of our meetings because it's a wonderful opportunity to get to know people who are like-minded and believe in the things that you believe in. Anyway, it's late. It's bedtime on the East Coast. Thank you, everybody, for joining us tonight. Thank you so much for participating in the research, however you did. Please stay in touch. And again, if there's parts of it that don't feel right for you, that's fine. We're interested in supporting physicians and renewing physician autonomy however we can.